everyone, and thank you, Shruti, for this wonderful introduction. So I am going to take away with discussing how to diagnose TTP. These are my disclosures. And I have 3 short learning objectives for today: define thrombotic microangiopathy versus thrombotic thrombocytopenic purpura, discuss clinical presentation and approach to diagnosis of TTP, and finally, just a few slides on how to approach the diagnosis of other TMAs. So what is thrombotic microangiopathy? Usually patients present with low platelet count, anemia, biochemical evidence of hemolysis, fragments on the blood film or morphological evidence of hemolysis, as well as evidence of organ damage by microthrombi. Traditionally and most commonly, the organs that are affected are kidney, brain, and heart, although we are progressively recognizing that other organs may be affected as well. So what is TTP then? Well, think of TTP as a type of TMA, but a type of TMA that is specifically caused by a severe deficiency of ADAMTS13. ADAMTS13 is a very important protein. It cleaves von Willebrand factor and prevents from accumulating large von Willebrand factor multimers, which, of course, if they start to accumulate, will interact with platelets, resulting in formation of microthrombi in the vasculature and organ damage. Furthermore, it is the strings of von Willebrand factor clogging the vasculature that is thought to be responsible for shredding or fragmenting the red blood cells and consumption of platelets. Severe deficiency is defined as ADAMTS13 activity of less than 10%. There are 2 types of TTP that are recognized. The ones that I see most frequently as an adult hematologist is the one of autoimmune form, where the ADAMTS13 deficiency is a result of IgG autoantibody directed against ADAMTS13 protein, leading to its neutralization or inhibition. There is a hereditary form, and this one is due to a genetic defect in ADAMTS13 gene, and it is much more rare to see it in adults, but is a very significant diagnosis to be considered in pediatrics. So what is the incidence of TMA versus TTP? And we don't have very much information on this, but we do have some data from Europe and United States. The annual incidence of TMA is thought to be around 4 cases per million, whereas the annual incidence of immune TTP is thought to be about half of that. It is also important to point out that epidemiology of TTP is different from other TMAs, with predominance of women in the 3rd to 5th decade of life and preponderance of patients with Black ancestry. Just as Shruti already mentioned, presentation of TTP is highly nonspecific and variable. People may be presenting with just weakness, abdominal pain, maybe confusion. Many other conditions can look like this. And just as Shruti said, I cannot emphasize it enough, even though pentad is still taught in medical schools and all our trainees are aware of the pentad, do not look for the pentad. And it is, when you do see it, recognize it as a sign of a very, very advanced disease. Hopefully the diagnosis should be made before complications like severe neurological complications and cardiac damage have already occurred. It is also important to point out, because most of us think of TTP as a thrombotic disorder, which of course it is, but you can have mucocutaneous bleeding as well. So petechia and menorrhagia, epistaxis are common presenting features. It is also important to recognize that patients may be clinically well at the beginning, presenting perhaps only with some abnormal lab tests, or they could be critically ill right at the presentation. Presentations are atypical, and I've already highlighted that it is more atypical in older patients, but Shruti is absolutely correct. Pediatrics is also a challenge. Degree of thrombocytopenia and anemia may be quite variable, and that may impair diagnosis. And since we are very much looking for red blood cell fragmentation, to trigger the thinking about this diagnosis, unfortunately, fragmentation may also be absent or inapparent at the beginning and only with serial blood films eventually be discovered. One other thing I'm going to mention is that TTP generally occurs as an isolated condition. However, in a portion of cases, it can coexist with other conditions, such as, for example, pregnancy help or lupus, making the diagnosis of TTP potentially more challenging. TTP is associated with acute organ damage. Right at presentation, about half would have already abnormal cardiac enzymes. Half would have mild kidney dysfunction. Severe kidney dysfunction is uncommon in TTP. Half would have neurological complications, with transient focal events being common amongst the more serious neurological presentations. And mortality without rapid treatment is very high. So in the past, the mortality exceeded 90%. Moreover, mortality was very rapid. So some of the older manuscripts talk about death occurring within days of presentation. Therefore, it is fundamentally important to suspect TTP and treat it because it is immediately, rapidly organ and life-threatening. The differential diagnosis of TTP is extensive, and this also adds to the complexity of managing this condition. As I've already discussed, there is TTP that can be either hereditary or immune. And as I mentioned previously, TTP can be primary, which is the majority of cases, but sometimes can co-occur with other conditions or exposures to medications. There is hemolytic uremic syndrome, of which complement mediated is more rare, and it can be either genetic or autoimmune. And much more common could be a result of a staph bacteria infection. There is disseminated intravascular coagulation, and there is, in adults, a long list of secondary TMAs. Some of them are thought to be complement amplifying conditions. Some occur as a result of their own unique underlying pathophysiology. Suffice it to say, the list is quite long. To make matters even more complicated, there are a number of conditions that are not TMAs, but can appear as TMAs based on some common features. So, for example, vitamin B12 deficiency can present with very significant anemia, thrombocytopenia, and very impressive markers of hemolysis. Sepsis can have a lot of features suggestive of TMA as well. So, how do you approach the diagnosis? So, I think there should be 3 basic steps. If you encounter a patient in whom you suspect TTP, first and foremost is to confirm presence of TMA. So complete blood count to look for anemia, thrombocytopenia, and of course look for those fragments on the blood film. Then order hemolytic markers. Now, here I've listed all of the hemolytic markers that I could potentially think of, but I would recommend use the ones that are available in the institution, the ones that you're comfortable using and interpreting, and the ones that have a rapid turnaround time. No point in ordering heptoglobin if this is a test that is done every 3 to 4 days. You're going to lose the diagnosis and ability to treat early. The second is to assess target organ damage. For heart, I recommend cardiac enzymes, so some variation of troponin. Kidney, creatinine, as well as urinalysis and ACR can be very, very helpful as well. And for brain, of course, we always think automatically that we should move immediately to imaging, but neurological exam is the key here because this is something that you can do right away and pick up abnormalities right away. Scanning can occur later on once you have moved on to treatment. And finally, consider differential diagnosis and use a prediction score. I'm not going to spend any time talking about diagnostic prediction scores because we have talk following mine on that. Suffice it to say, there is a French score and the plasmic score, and both include elements of both laboratory investigations as well as history. And you add the points, and the points translate into the probability of your patient having severe ADAMTS13 deficiency. Again, very important to point out, scores are really good. They might be very helpful. Nevertheless, TTP is a clinical diagnosis, and any TMA with organ damage without alternative immediate explanation is TTP until proven otherwise. There are a number of groups, again, pointing out pediatrics and elderly, where the prediction scores may not perform well, and you may miss the diagnosis. It is really important to try to obtain ADAMTS13 activity to confirm diagnosis. This is important so you can move on with specific TTP treatments, as well as to rule out TTP and move on with supportive as well as specific treatments for the host of other conditions that I have presented. Severe deficiency of ADAMTS13, less than 10%, has very high sensitivity and specificity. It is important to point out that some other conditions, including sepsis and even complement-mediated HUS, where you can witness moderate deficiency. It is important to collect your specimen prior to giving any plasma to the patient. And yes, this test is not readily available in all laboratories. It may need to be sent out. It may have long turnaround time, although I think every effort should be made to have this test available for all patients. What about ADAMTS13 antibody? Well, the main utility of this test is to differentiate immune versus hereditary form. ADAMTS13 antigen is less frequently available and may have some prognostic value in managing acute presentation. And finally, the new one is ADAMTS13 confirmation, which may predict relapse. The most important thing, of course, to remember is that even though I do want you to take away that you absolutely have to perform ADAMTS13 testing to confirm the diagnosis, that you do not wait for the results to come back, recognizing that not all of us may have rapid access to this test. It is important to start treatment as soon as possible. And the treatment you should start when you suspect TTP is plasmapheresis and corticosteroids. And according to the British guidelines, it should be within 4 to 8 hours. So do not delay it. Once diagnosis has been confirmed, you can order potentially other important treatments for TTP, such as further immunosuppression, anti-VWF therapy, recombinant ADAMTS13, whatever that might be, and whatever is available. Delayed time to TPE has been shown to be more common in patients who are older, in patients with higher platelet counts, and those who do not have fragments on the film. So you do have to maintain high index of suspicion, and remember that delay in treatment, delay to TPE, delay to plasmapheresis does result in increased mortality and higher healthcare costs. So what if TTP is unlikely, or you've already received the result, you've already performed the testing, and ADAMTS13 activity is normal? What else should you be doing? Well, the things that you can perform right away, even in the emergency room or in the first days of hospitalization with a very rapid turnaround time, would be assessment for malignant hypertension, assessment for hypopreeclampsia, DIC, vitamin B12 deficiency, Evans syndrome, which is a combination of autoimmune hemolytic anemia and immune thrombocytopenia. Pancreatitis, you can do a rapid screen for both medications as well as substances of abuse that are associated with TMA. With a little bit more time, you can screen for malignancy. Disseminated malignancy, especially involving vasculature or bone marrow, can look very much like TTP. Screen for infections, screen for rheumatological autoimmune conditions, screen for complications of transplant, and of course, do not forget complement-mediated hemolytic uremic syndrome. While you are performing these investigations, provide supportive care, manage blood pressure, manage volume, support renal function as necessary, and once you have pinned down the diagnosis, rapidly move to the most appropriate therapy for these conditions. So I'm going to demonstrate a very quick case of applying the principles that I've just discussed. So this is a composite case, but based on real presentations of a few individuals. So 22-year-old female presents to the emergency room with abnormal test result. She saw her primary care doctor about 2 days ago because her period was too heavy. She was instructed to go to the emergency room following laboratory tests. She doesn't have any significant past medical history, and her only significant physical examination finding is that she has petechiae and bruising over extremities. Her laboratory tests are presented there, so she's got mild anemia, severe thrombocytopenia, no other cytopenias, and the rest of her investigations are depicted there and essentially are non-contributory. The hematologist on call reviews her case, reviews the blood film, and she is one of those unlucky patients with no fragments on the blood film, and therefore TTP is not suspected. In fact, she gets diagnosed with a much more common condition, immune thrombocytopenia, and gets treated with appropriate ITP regimen. There is this question of elevated LDH, but it is attributed to sample being hemolyzed, and no further attention is being paid to it. If we pause and think, could this be TTP? If we do a quick 1, 2, 3 approach, let's assess for TMA. We're not sure. She's got reticulocytosis, she's got mild thrombocytopenia, anemia. There is an elevated LDH, but there are no fragments. Interestingly enough, her troponin is elevated, her creatinine is normal, and she has no neurological complications. So there is still quite a wide differential diagnosis here. If you apply plasmic score to this patient, even without confirmation of hemolysis, prediction of severe ADAMTS13 deficiency, her score is actually quite high. And this should have raised suspicion that we are dealing with TTP, and she should have been started on plasmapheresis. Unfortunately, this wasn't done, and over the ensuing day, she is getting neurologically unwell. And when you follow her blood films, you actually start to appreciate very slight increase in RBC fragmentation. The rest of the tests come back, also ruling out some other important etiologies, and heptoglobin being undetectable confirms that she is in fact hemolyzing. She has been started on TTP treatment, and subsequently, not surprisingly, ADAMTS13 activity came back as severely deficient with a high inhibitor, consistent with diagnosis of immune TTP. So in conclusion, TTP presents with microangiopathic hemolytic anemia and thrombocytopenia. Many conditions may look like this. Differential diagnosis may be extensive. Severe ADAMTS13 deficiency confirms diagnosis of TTP. TTP can cause death or severe organ damage rapidly, and therefore, if this could be TTP, do order ADAMTS13 tests. Do not wait for the results and start treatment as the patient has TTP. And finally, just a few reminders for those who assess these patients for the first time. It's the first point of contact in the emergency rooms. Remember, clinical presentation can be very heterogeneous and nonspecific. Do not say this is not TTP because they don't have neurological dysfunction. Do not say it's not TTP because the patient just looks way too well clinically. This can change very rapidly. Remember that any patient with a past history of TTP who is now presenting with thrombocytopenia, first and foremost, on the differential diagnosis must have TTP relapse, and you do not discharge them until you've proven otherwise. Consider TTP in any patient who presents with acute focal deficit and a new thrombocytopenia, especially more severe thrombocytopenia. And always order hemolytic markers and blood films in the patient who presents with significant thrombocytopenia, have a low index of suspicion. Thank you so much for your attention, and I'm going to now over to you, to our moderators.
Thank you so much, Katrina, for that wonderful talk. I was especially engaged by the part where you really highlight the importance of reviewing the smear again and not losing track of the possible diagnosis of TTP. I think that was critical. Thank you so much. And now it's my very great pleasure to introduce Dr. Spiro Catland, who is a professor of medicine at The Ohio